Hey folks, another end of the day case here I wanted to share with you. I had a patient this morning that I had seen the day before for a consultation, and this patient had came in with a chief complaint of pain in the upper left quadrant. Did the testing and the diagnostics. Turns out that the second premolar, tooth number 13, was testing necrotic. Adjacent teeth were positive to temperature testing and negative to cold, but number 13, the first premolar, was negative to cold and positive to percussion. Of course, this tooth was virgin, so usually when you see a situation like this, you need to kind of suspect either some type of a perio-related necrosis or a crack. And in this tooth, clinically, when we take a look, we see that there is a mesiodistal line that's running across this second premolar, indicating that there is a crack present. So that's how the bacteria gets introduced into the pulp. Now, there was no probing all around the tooth. However, in the mesial, there was some bleeding upon probing, and that indicates that the crack is probably just, a little bit past the coronal area of the tooth, so into the attachment. That's probably what's causing the bleeding upon probing. And of course, on the periapical radiograph, you can see a little bit of breakdown of bone in the mesial aspect of the tooth at the crestal bone level. And a CBCT was obtained to take a look at this tooth, and we can see that there is some bony breakdown in the mesial aspect of the tooth. So at this point, the real question is, what do we do? Is this tooth savable or not? It's a virgin tooth. Now, the patient is a physician, and in fact, a very accomplished local physician from Harvard, who's developed a lot of different medications and drugs, as a neurologist. And so what do I tell this patient? Should we try to save your tooth or not? Now, typically, in general, I would be telling a patient that has a mesiodistal crack of this extent with some bleeding upon probing, although the tooth is not really probing deep, I would say that the prognosis is guarded. And if someone is really interested in a long-term prognosis, a tooth like this is probably best extracted and replaced with an implant or a bridge or whatever the substitute is. This patient, however, being of a higher dental IQ, understanding the nuances of treatment planning and the unavailability of knowledge in retrospect, kind of understood that, look, the long-term prognosis is guarded, if anything, of possibly poor, but he was very adamant in trying to save the tooth. And even he said, if I can even get a couple of years more out of this tooth, I would be happy. So understanding that, I usually personally do not like those types of odds, because for me, anytime any of my cases fail, it's not speaking very highly of my treatment planning. So I always like to have long-term treatment planning, and for me, a minimum amount of time to keep a tooth would be 5 years. But as long as the patient understands what the risks are, I usually tell them that the risk involved here is time and treasure that you would lose, and it's very possible that you could go through this, and if it doesn't work very soon, you'd be back at square one. At that point, you have to remove the tooth. So patients have to understand this concept, and if they do understand, then you can move forward. Oftentimes, however, what I see is that we make that decision for the patients one way or another. Either we say the tooth is not savable, it has to be pulled, or we say that give it a shot, not fully committing or communicating with the patient about their priorities and their values. And that's a really significant part of the treatment planning, which I wanted to bring up as an example in this particular case. I do teach a treatment planning course at the Harvard Postdoc Endo, and these types of cases come up all the time because you're trying to mitigate risk. And that cannot happen based on your personal value system. You need to be able to figure out what works best for a given patient, not universally, not based on studies, not based on anything else, but what is best for one given patient. And in order to come up with a solution or a proper answer that applies to that given patient, you need to spend a little bit of time interviewing the patient and understanding what their priorities are. Of course, that's a difficult conversation with many patients. The average patient just don't know. They just want you to make that decision. And usually in that case, then you make a call based on what type of a practice philosophy you have, and then you kind of just make sure you kind of communicate that properly with your patient. In this case, however, as I mentioned, this was a fairly accomplished physician patient who fully understood this idea. And, you know, a quote I told him that I often say is that dentistry is the slowest way to lose your teeth. And he said this, of course, is the same way health is the slowest way to die. So, without turning the conversation into a morbid conversation, we proceeded to try to save the tooth. So we accessed the tooth and got down there. I wanted to use as much as possible, a more minimally invasive type of a preparation without enlarging the tooth coronally too much. So I went with a regular endosequence 04 taper files, used the size 25 in a crown down fashion, followed by the 20, got the length, and then 2004, and then got the 25 to the apex. Of course, 25 is not adequate for this type of a size. What I did is I used then the 3502 race file so that I could just cork out the apex and clean the apex out without really removing additional taper. You can do that by combining the 02 taper files or even the Scout and the sequence files for that specific purpose. Anyway, in this case, which was a little bit curved as well, we managed again to get down to the length and fitted a size 25 endosequence cone and seared that off. And at this point, I wanted to backfill all the way up with the BC liner in order to get some type of a bond coronally and hopefully be able to strengthen the tooth through internal bonding using the liner material. At this point, I made a decision to trough out the cracks and just on the distal, because it was probing and because I could see some material debris into this space, I wanted to clean that out. Now, I'd be curious to hear your feedback as to whether you think troughing it out was a good idea or not. I'm on the fence about it. I don't know. In this particular case, especially on the distal, I'm glad I did because there was a lot of staining, and I think there was even perhaps some decay had begun to form. Maybe the crack was a little bit on the older side and had decayed, and then that's what probably caused the necrosis. In which case, actually, that's a better prognosis than just the crack itself causing the necrosis. Anyway, so went on there and etched it and bonded, and then put the liner in and filled all the way to the top and completed the case here. There was no mobility, neither of the segments nor of the tooth itself prior to the treatment. What I would do in these types of cases most of the time is I take a part of the chance with the patients. If I end up doing the case where I know the prognosis is guarded, what I tend to do is I have the patients come back within a couple of months, and in 2 months' time, there is adequate healing from the root canal that has taken place. The tooth should be otherwise completely asymptomatic. So by having the liner in there, the tooth can remain in that state of provisionalization for 2 months, and I can assess the healing of the tooth and the crack and the periodontium and figure out what I'm dealing with. If at that point the patient feels anything with the tooth, if it is one of those where they tap it, they have some sensation, or the tooth is uncomfortable to chewing, I would consider that not working, and then I would recommend the patient to remove the tooth, and I would actually reimburse the patient the cost of the root canal. And I do that, of course, because I want to make sure that in these types of cases, I get a chance to see, because there's something in it for me to learn from the outcome of the procedure by finding out if this case would have worked or wouldn't have worked. And I don't want the patient to be taking a financial risk with that. So in that situations, I would reimburse the patient after a couple of months. I actually would usually do that up to 6 months after, if the case fails because of this crack. And after that, it really is a function, as I mentioned, of communicating with the patient, so the patient really understands that the tooth was not a good prognosis to begin with. So this is one of those interesting cases where there's a lot of treatment planning involved. You're trying to make a decision based on an unknown future, and I'm again curious to hear your feedback, and I'd love to see what you guys would do in cases like this, and what you normally do. How do you manage it? So we can all maybe together find better ways of perhaps improving the patient care that we render in those cases that they can get away with it and get the tooth saved, save the tooth, and in those cases what we can't, really remove the tooth. Of course, in general, for me, if the crack line, when I look into the tooth, goes beyond the orifice of the tooth, I do not try to save these. In this case, I created actually little steps so I could just see if the crack continues on the mesial aspect of the tooth, and I didn't see it go deeper onto the root beyond with using the microscope. And that's part of the reason why I felt like I would still take a chance. If I see it go on the root surface, I would not even give the patient the option, because those cases just do not fare well and shouldn't be even attempted to save. Anyway, I hope there was something to learn in this case, and I think together with these treatment planning cases that I will hopefully be providing based on my daily cases that I see here in my office, we can all come together as a consensus and find out what is really the best way to treatment plan patients so that they can get the most out of their teeth while we all look like heroes of saving their teeth. All right, I hope this was helpful to you, and I'll see you in the next video.